So thank you again for the kind invitation. And also it's a privilege to be on the same podium as Dr. Schechter, who I just met for the first time yesterday. So that's even a greater privilege, so thank you. So I'm talking a little bit about older people, which is what I do. Just a little set the tone. Some of the people who've thought about aging, we don't grow older, we grow riper. Roosevelt said beautiful young people are accidents of nature, but older people are works of art. And the minute a man ceases to grow, no matter what his years, that minute he begins to be old. To a great American philosophers, one Benjamin Franklin said, all would live long, but none would be old. What Benjamin Franklin understood was that what we now term in geriatrics as compression of morbidity. In other words, you live a healthy life and try to compress the period of time that you're sick, really just to the end of life. And Mark Twain said, age is an issue of mind over matter. If you don't mind, it doesn't matter. Da Vinci also looked at aging, talking about the virtues acquired in youth, which will keep you in good stead into your older age group. Rembrandt took the first selfie. Did you know that? Rembrandt had many, many self-portraits. So I just put up his own 4 stages of aging, just as some perspective. And I like Dutch masters anyway, so it's a good excuse to show it. Now, we talked yesterday about how older people are really underrepresented in clinical trials and to a very large extent get substandard care. I think part of it might be this issue about how older people are portrayed in society and are thought of in society, at least in American society. So I had this reference, the media takes on aging, and you could see here on the right a number of pejorative terms, negative terms about older patients, older people in society. So very often elders are portrayed as helpless victims. They presented as negative stereotypes, bizarre and comical, like on television and the movies. Growing old is equated with inevitable deterioration and decline. Elders are demonized, and they're underrepresented and often ignored. They're important consumers, not just for Viagra and Depends. In our society, at least in American society, we need our elders. This is the United States Supreme Court, and they, to a very large extent, are extraordinarily influential in American society and American lives. This is at Memorial Sloan Kettering. This is really our mentor, the person that we really look up to in terms of aging and how we think about the virtues of older patients. This is Jimmy Holland. She's truly the founder of psycho-oncology. She's a member of our 65-plus clinical geriatrics program. She's 87 years old. And as she got older, she thought a lot about aging, and so she just wrote this book, which is very good, and it's called Lighter as We Go, Virtues, Character, Strengths, and Aging. She wrote it with one of her colleagues, Mindy Greenstein, and if you want to get a good feeling and a good philosophy, it's really not just aging, it's how to be a good person. I would advise you to read this, and it all goes to charity. So we treasure her very much. So yesterday, I talked about geriatric assessment, and I just wanted to go over a few things and reinforce a few things. Evaluating an older patient does not have to be complicated. All you have to do is watch the patient walk, ask a few simple questions about falls, IADL, comorbidity. Are they anemic? Do they have renal disease? Are they socially isolated? Because social isolation is actually a risk factor for complications of chemotherapy and surgery. You have to establish a database. You have to start somewhere. How did your patients do? We can't treat older patients with anecdotes. I treated an old person once or whatever. We really have to look at our record of how we treat patients, who we treated, who we didn't treat, why didn't we treat them, why did we treat them differently. And I think then we'll really learn how to treat patients in the future. So again, increasing incidence of cancer with age. Other medical problems complicate cancer treatment. Patients do not participate in clinical trials. However, we can somewhat predict the risks of side effects and toxicity. And I showed this yesterday, how most clinical trials involve patients that are 10 to 15 years younger than the disease which we're treating in the general population. Patients on clinical trials are the best patients, the healthiest patient, and are not almost never representative of the actual patients we see in day-to-day practice. Excuse me. Okay, so should we do elderly-specific trials? This is an area of controversy. Going back to 1980, this was an article published by Colin Begg about the experience of the Eastern Cooperative Oncology Group. He talked about how older patients did not experience any increased toxicity with the increased frequency. They were compliant with drug regimens on protocol. Their response rates were equivalent. And his recommendation was these have important implications for cancer management and the elderly. This is 1980. That's when I graduated from medical school. In 1989, Harold Freeman talked about cancer, breast cancer in older black women, and these are very poor women in Manhattan, New York City. The JCO published in 1991 an article by B.J. Kennedy about the need for clinical trials in older patients. In 1992, the National Cancer Institute published a paper on the underrepresentation of older patients on clinical treatment trials. In 1999, Dr. Hutchins from the University of Arkansas published this article in the New England Journal of Medicine talking about the underrepresentation of older patients on cancer treatment trials of the Southwest Oncology Group. In 2002, another article talked about how we have to increase the number of older patients on clinical trials. I think you get a trend here. And this was, I showed yesterday how we really have no data no objective data, no evidence-based data to really treat patients over the age of 75, and particularly over the age of 80. In 2004, the FDA looked at their clinical experience on drug registration trials and showed that older patients were, again, underrepresented in clinical trials. And if you look at the package inserts of most drugs, and you look at the section that says geriatrics or older patients, usually it either has a blank or there's not enough data or whatever. And in 2012, this paper came out about the underrepresentation of older cancer patients in registration trials, known problem, little progress. So I encourage you to contribute to the effort, and we're trying to make these efforts. And why does this happen? To a very large extent, it's physician-driven. This was an article published actually in 2003, Barriers to Clinical Trial Participation by Older Women with Breast Cancer. And it looked at institutions in which clinical trials were available, the patients were eligible, but they weren't entered onto the trial. And one of the findings was that the greatest barrier to participation was that physicians did not recommend participating in those trials. And there are a myriad of reasons for it, and I'm hoping maybe now it's not quite the same burden. Part of it was there weren't the really elder-specific trials available, and now that there are more elder-specific trials. So if we make the assumption that our current clinical trial structure for cancer treatment trials is adequate for older patients, and we don't have to make a change, but I think the evidence is that it's not a good clinical trial structure, and we need to encourage participation or change the trial structure. So I'm going to talk about some design issues, and I'm a medical oncologist, so you have to forgive me, so I'm going to talk about drugs just a little bit. I don't know anything from surgery. I'm going to talk a little bit about pharmacology because drug therapy is really critical to older patients. They take most of the pharmaceuticals and they experience most of the toxicity. So first thing is absorption. I'm going to talk a little bit about pharmacology. One of the greatest problems to absorption is patients don't take their medicines appropriately. Compliance, whether that's due to polypharmacy, they get confused of what to take or take it inappropriately, or at least in the U.S. we'll call it financial problems in terms of access to medication. Body composition changes with age. There is different change in physiology. Older patients, particularly sick older patients with cancer, are often hypoalbuminemic. They have poor distribution, whether due to that, heart disease, renal disease, and this can affect drug metabolism and distribution. One of the great issues is drug interactions and interactions with cytochrome P450, and primarily this is an issue of polypharmacy. Again, patients are taking multiple medications, which is involved in the P450 system, which accelerates drug interactions. The most common drugs that are taken related to this are anti-cholesterol drugs, such as simvastatin, the statins. In a review of 100 patients over the age of 70, median age of 74, we evaluated these patients. The number of medications the patients were taking at their first visit was 8. The range is huge. 8 is actually probably an underestimate. At least 25% of the drugs they're taking potentially can interact with P450. Why is that important? It's a potential for drug interactions and toxicity. Many patients, particularly cancer patients, are taking complementary and alternative medications, and they usually don't tell the physician unless they're absolutely directly asked, or they don't perceive of it as a medication. And there's something in geriatrics called the Beers list, which is a list of medicines that older patients probably should not be taking because of fall risk. One of the ways a physician and a healthcare establishment could help older patients is the evaluation of polypharmacy. Again, polypharmacy is this huge number of medications that patients take. And many institutions are using geriatric pharmacists, or just the nurses in our office and the physicians can go over patients' lists. And there was just this publication from Thomas Jefferson University looking at a very good way of evaluating polypharmacy, and an editorial I wrote which describes how you could introduce this very simple thing into practice and make a huge improvement in patient care by reducing toxicity and increasing drug compliance. So the drug interactions are extremely important, and they're also important because many of these medications exclude patients from participating in clinical trials, and it emphasized the importance of minimizing concomitant medications, and it reduces the risk of hospitalization and adverse drug events. As we age, we have a decline in glomerular filtration. We know that it's associated with a normal physiology of aging. And then if you put on top of it comorbidities such as diabetes, hypertension, heart disease, nonsteroidal anti-inflammatory drugs, and all the things that we're exposed to, that also exacerbates renal dysfunction. Small changes in serum creatinine can result in huge changes in renal function. And when you dose drugs to patients in any setting, whether it's pain medicine, post-operatively, pre-operatively, cancer treatment, whatever it might be, you always have to keep in mind these very subtle changes in renal function can make a huge issue with toxicity from therapy, such as delirium, and delirium leads to a number of adverse events. So please keep this in mind. Patients with normal serum creatinines who are older, usually have abnormal renal function. So 2/3 of the patients with normal serum creatinines have abnormal renal function. So just to remember that serum creatinine alone is insufficient as a means of evaluating renal function. And we use these formulas, but in extremes. And a lot of our patients are either obese, or the cancer patients have lost muscle mass and are cachexic. These formulas really fall apart, and you really have to take them with a grain of salt. There may be some clinical consequences of these, because you can alter clinical trial eligibility, because many clinical trials, no matter what the drug is being evaluated, you have to have a certain creatinine clearance, whether the drug is renally cleared or not. Or there may be a misperception of drug safety, because as patients lose muscle mass, they have a perceived increase in creatinine clearance, which is really factitious. It really is incorrect. We looked at a number of studies in cooperative groups looking whether it's appropriate to exclude older patients from clinical trials based on just small changes in renal function. And we looked at outcomes, and I looked at the outcomes of the Cancer and Leukemia Group B's breast cancer studies in older women with breast cancer. There was no increase in toxicity or outcomes with appropriate dose adjustment. And I have to emphasize, appropriate dose adjustments to their renal function, and you could treat patients safely. And to exclude a patient on a clinical trial just based on that alone may not be appropriate. And looking at the gynecologic oncology group data, Dr. O'Carroll from Sloan Kettering found the same, came to the same conclusion. So when we're looking at drug therapy, traditionally drugs have not been studied in older patients like I showed you. Drugs have been studied in younger patients, which I call the typical patient. However, we've learned a lot over the years about how to dose therapy in patients with comorbidities, such as renal or hepatic disease. When we have studied older patients, interestingly, there have been few changes, very few changes, which have been related to age alone. The pharmacokinetic differences has really been irrelevant, and the patients, other than having a comorbidity, such as renal disease, which changes his pharmacology. One of the great needs in clinical trials in older patients is looking at changes in toxicity over time. We really have never done that, and it's very difficult to do, but it's something we really have to consider. One of the other impediments of studying older patients on clinical trials is, again, the heterogeneity of aging. And very often there's a lot of variability, and it makes definitive conclusions difficult. So we do have to study a larger group of patients. When we're looking at drug toxicity, and this is not just with chemotherapy, but I'm using this as an example, that drug toxicity very often is not the drug, it's how we give the drug. So in colon cancer, giving 5-FU, we've learned over the years that bolus therapy is probably the worst way of giving 5-FU. It's the most toxic, and that's why we've evolved into giving infusional therapy as we do now in the FOLFOX regimens. Taxanes, which we use for breast cancer and gynecologic cancer, we know that there's a totally different spectrum of toxicity whether the drugs are given weekly or every 3 weeks, or intraperitoneally for that matter. We've never ever explored the pharmacogenomic components of toxicity in aging. Now, our genes don't change as we age, but there are certain susceptibility genes that may be interacting with comorbidity that may exacerbate and increase the risk of certain toxicities as we age. When we're designing clinical trials, we really have to be very careful about which type of patient we're studying. I mentioned yesterday it's very important to differentiate between the healthy, the vulnerable, and the frail. Doing clinical trials in frail patients is more of a palliative care kind of study because they really are not appropriate candidates for standard therapies. Should we allow patients who are anemic, hypoalbuminemic, dependent patients? And these are issues which are facing us because many of the older patients with cancer have some of these characteristics, particularly dependency, and how to study that is one of the tasks that we're exploring in our cooperative groups right now. What do you do with patients with multiple comorbidities? And about 20% of patients 70, 75 years of age or older who develop cancer have already been treated for cancer for something else. And how do you factor that in, their previous exposure to chemotherapy and radiation? So again, toxicity of therapy is a result of the many factors that I've mentioned, comorbidities, prior exposure, etc. There's some physiologic changes in organ function. And again, comorbidity further changes organ function and pharmacodynamics, that sensitivity to toxicity, such as the diabetic who will get more neuropathy when exposed to taxanes and platinum, the person who gets cardiomyopathy who has pre-existing heart disease after exposure to anthracyclines or trastuzumab for breast cancer. So again, these are very, very important issues to consider. So what should we study? What are some of the critical issues in older patients and cancer therapy? Well, many of the new drugs that we use now are oral. The targeted therapies, not all, but many are oral, for melanoma, for breast cancer, etc. So compliance. Most compliance studies show that if you take one prescription drug, compliance is only 70%. What do you do with patients who are taking 10 to 15 drugs, and then you add an oral therapy for their cancer on top of it? Are they really taking it? We have to study drug interactions and the longitudinal effects of treatment, changes in cognition, changes in function with treatment, and does treatment increase dependency, and the correlation of toxicity and function. This longitudinal effects of therapy and survivorship issues are extraordinarily important. We don't want to make an independent patient dependent. The EORTC, the Alliance, and the SIOG published this paper 2 years ago looking at appropriate endpoints of clinical trials in older patients, trying to rethink and think out of the box in terms of how we should look at studies to make them the most valuable. So is survival an appropriate endpoint for an older patient on cancer treatment? It may not be. Because one of the questions is the patient going to die of or with cancer? And that's a big issue in relatively indolent diseases. So that has to be considered. Should we look at response? That's the traditional way of evaluating drugs, which we should still look at. But I think in an older person, what's more important is the functional and clinical benefit, maintenance of quality of life, and maintenance of independence and avoiding dependence. And the other issue, many of the drugs we give, their major toxicities are non-hematologic. They used to be hematologic. And are our scales that we traditionally use to evaluate patients, are they appropriate for older patients? If you give an older patient neuropathy from therapy and they can't drive a car, they can't open a door, that's a highly significant toxicity. And are we really measuring that appropriately? So some patient-oriented toxicity scale would be extremely valuable. We have geriatric scales, which I mentioned yesterday. I don't want to belabor that. When we do have patients on clinical trials, do we report the data appropriately? And in this review that I wrote, I really looked at a number of studies and showed that even when older patients were participants in the trials, the journals were underreporting the patients and how they experienced the therapy. Like, were the older patients the ones getting the toxicity or not? We really do not know. And I urge people who are involved in journal editorial processes or reviewing papers to think about it when they look at a paper, and if the age range is in the 70s and 80s, how is that data being reported to help clinicians make decisions? So I mentioned yesterday about predicting toxicity, and I just wanted to point out that in that toxicity scale, which was superior to clinical judgment, I always have to remind us, is that you would think that renal function and anemia were very important, which they are, but I just wanted to point out that hearing deficits was important, the number of falls again, IEDL, walking speed, and very interestingly, social isolation was an adverse prognostic factor for therapy-related toxicity, whether that's due to inability to call the physician, get to the emergency room, or whatever. Social isolation is a very important issue. So when a cancer patient comes to our office by themselves, we always get nervous. We talked about IADLs yesterday, and I showed that it's associated with decreased survival in older patients. So again, asking those simple questions about shopping, polypharmacy, using the telephone, etc., amazingly predicts survival. It's really fascinating, actually. Cancer increases the likelihood of becoming vulnerable and frail, and that you may not be surprised at that, but just to point that out. Again, a myriad of assessment tools. It actually does not matter which one you pick, as long as you're consistent and think about the results. So it could be the G8, it could be the VES13, it really doesn't matter. We've spent a number of years trying to figure out what's the best. We've come to the conclusion if it's validated, it's okay. I mentioned gait speed yesterday. That's why I said watch your patient walk. And these are the things that are going to be included in clinical trials such as e-prognosis. The issue about falls, again, greater than 4 falls predicted post-operative complications. And the time get up and go test, which if it's done normally takes less than 30 seconds. So this is certainly not time consuming. So why do we do any geriatric assessment? It's the detection of unidentified problems, prediction of adverse outcomes, and gives some sort of sense and estimate of residual life expectancy and how well the patient can potentially benefit from therapy or participation in a study. There are a number of screening tools which I've mentioned, and again, it really is irrelevant which one you pick. An institution can pick one, the nursing staff could pick one, whatever you like, but if you use the one consistently and learn how to use it, it can be very valuable. So looking at these 2 performance tools, they were highly predictive with very simple questions such as a caregiver, again, the walking speed, polypharmacy, all the things that I've mentioned. These are not complicated issues or complicated questions. Again, these tools are highly predictive of survival. So if you're embarking either on a study or a procedure or something on a patient, you want to get a feel for will they live long enough to really obtain the benefit of what we're doing, these are the tools we need to help us make those decisions. So there was a recent meeting it's called our U13 meeting, which was a meeting trying to move the field forward and trying to reorganize and starting to design clinical trials. Dr. Hurry is the director of the Cancer and Aging Research Program, and I stole her slides. And just to give some thoughts about redesigning clinical trials, using the things that I mentioned as part of a research study. So the question is, how do we geriatrize the standard oncology study design? Well, the standard therapy is we have eligibility, intervention, and an outcome. We have the standard oncology design. We're going to add a geriatric component, try to find gaps in knowledge. So in terms of eligibility is patient age, obviously, traditionally going back 20, 30 years, patient age was capped. We don't do that anymore, or usually. The disease, the organ function, we really have to rethink those kind of things. Performance status, comorbidities. We make it intervention, a drug therapy, a combination versus a single agent, or a non-therapeutic intervention such as an exercise program or nutrition, and measure an outcome. Disease-free survival, overall survival. So that's the standard design. How do we geriatrize those designs? Well, age. Remember I said, what older patient are we talking about? Should we just study healthy older patients? I don't think we're going to learn a lot. We have to study pharmacology. We have to study the biology of aging and the interaction of the biology of aging and cancer. What is our goal of therapy? That's always important. Yesterday I was asked about an 85-year-old patient, and what I really forgot to say was, what is really the benefit of that treatment? Are we going to get some marginal 5–10% benefit? What is the real goal of our therapy? Is it to make the CAT scan better, or is it to help the patient function better? We have to look at organ function, and performance status is much less important. Again, what I think you've come to realize is that what's more important than cancer performance status is functional status. So we have our therapeutic intervention. I mentioned this, we could look at novel study designs, looking at whether they're therapeutic or non-therapeutic trials. What people are looking at right now is a geriatric assessment-based intervention. In other words, you take patients, you could blind a group to the geriatric assessment, or in the other group, treat them based on the geriatric assessment and see if that really makes a difference. We have to have a collaboration between geriatrics and oncology. We have to rethink our research infrastructure to look for the needs of the older patient, whether it's geriatric training or environmental considerations, or I think what's very important, leveraging information technology, whether it's telemedicine, making a database, whatever it might be, because I think that'll be our probably most productive way. We have to look at patient-centered outcomes. Just survival, response, 10% response, 25% response is really probably not a clinically relevant endpoint for older patients. So we do have to look at function, cognition, toxicity, cost of therapy, and caregiver needs. We have to meld oncology outcomes and geriatric outcomes. So we have to take the traditional oncology outcome, look at the geriatric outcome, and come to some happy medium to try to get results that'll be helpful for patients in the future. Because we're really not doing that right now. So some key gaps, again, to reiterate, few studies in patients over 75, or I should say almost no studies. Few studies in the frail elderly, which to a large extent will be palliative care studies. We have a lack of standard definition of frailty, though we're coming closer to that. The question is, should we use a clinical definition, a biologic definition, or a combination? We have to do interventional studies, change clinical trial design, rethink clinical trial design, change the research infrastructure, define outcomes, because again, response and survival are not probably the most important outcomes, and meld geriatrics and oncology. So again, the older patients, the fastest growing segment of our society. In the US, people over the age of 80 are the fastest growing demographic group. They will carry the greatest burden of cancer. And in terms of management, we probably know the least about them. We really need to focus our efforts on this most vulnerable patient population. We need to carefully design trials to prospectively capture and evaluate important and predictive information. No anecdotes. They're helpful, but that's not how we could move ahead treatment. So since I'm in Israel, I got very inspired. Do not cast me away when I am old. Do not forsake me when my strength is gone. Again, please join SIOG and participate in our organization. And thank you very much.
Okay. Thank you very much for the informative talk. Any questions? Tania?
Thanks for both talks, and it's a very important topic, great talk. And I wanted to hear your take on the first step in recruiting patients to clinical trial. That's the informed consent. At my institution, for example, I think it's locally, in order to recruit a patient over the age of 74, I need to have a psychogeriatric evaluation, which is, number one, a hassle, and number two, sometimes insulting to suggest that to patients. So even if the equipment is just a single blood test, I practically can't recruit patients over the age of 74 unless I do something.
I mean, we don't require that, certainly. I mean, I've never heard of that to require it. I mean, the consent process is always a big issue. I was praying someone wouldn't ask me that, but you know, we have the problem with us with consent forms. Who are they, you know, the question always is, who are they trying to protect? They're really trying to protect the patient or the institution. They're trying to protect the institution. The patients don't read the consent forms. You know, I don't know how long the consent forms are here, but, you know, 20 to 30 pages is not unusual. But in terms of cognitive impairment, we don't do a formal test for patients on study unless that's the study you're doing. You're looking at cognitive impairment. So usually we don't do that unless, look, if a physician feels the patient is cognitively impaired and needs an evaluation or detects that, well, and they probably shouldn't be on the clinical trial. I mean, cognitive impairment itself is a is a life-limiting comorbidity which affects outcomes. So, and you know, all the therapies we give can exacerbate that and cause, you know, delirium, dementia, etc. But in terms of a formal evaluation, we don't do that. But I think the clinical, consent process is very difficult, and we clearly don't explain it right. I mean, there have been many studies about, forget geriatrics, I mean, do people really understand what a phase 1 study is, which is a study looking at toxicity and not effectiveness of therapy. Many surveys have shown that patients, because of maybe hope of improvement, they always assume that the therapy is for their benefit. But in reality, a phase 1 study is really not. So there's a communication issue. And if you throw cognitive impairment on top of that, that becomes even more of a problem.
Thank you very much.
All right, thank you very much.
And